All right. Hi, everybody. Welcome to the, it's now 12 o'clock, so we'll begin our session today. Thank you again, everyone, for joining us. My name is Lena, and this is the second session of the second series of the PPCL Perinatal Echo Program. I'll be the coordinator for today's Echo session. Jody West is typically our coordinator, but she's at a conference today, so she left me in charge. So I'll go over a few housekeeping items with everyone before we begin. This is our agenda for the day. We will do our best to adhere to this schedule. And after I complete a few housekeeping announcements, our facilitator, Dr. Olivier, will lead us in introductions. And then I will tell you guys a little bit about PPCL. And then we have Dr. Paula Zena, who will then present our didactic for today. We will then move on to our case presentation that will be presented by one of our hub team members, Katie Hebert. And after Katie presents, we will open the floor for clarifying questions, first from you guys, and then from the hub team. And once all of the questions have been answered, we'll transition to providing some recommendations. I will briefly summarize all of the recommendations, and then after that, we'll wrap up with announcements and close the session for the day. All right, Dr. Olivier, I'll pass it to you.
Thank you, Lena. Good morning, everybody, or afternoon. I always say good morning. It's right at that transition. Good afternoon, everybody, and thank you for joining us again on your lunch breaks. I'm Dr. Olivier. I'm one of the psychiatry experts on the hub team. I'm a child and adolescent and adult psychiatrist here in Lafayette, Louisiana, and I'm also the facilitator for these sessions, so I try and help us keep on the schedule and keep on time. I'm going to ask the hub team of experts to reintroduce themselves to y'all. You met Lena. She is also one of our social work experts on our team. We also have another social work expert, Katie. You want to introduce yourself?
Sure, I'm Katie Hebert. I'm an LCSW and perinatal certified, and I work in private practice with perinatal families, and I'm located at Bloom in Lafayette, Louisiana.
Thank you, Katie.
Sure.
Also on our team is Dr. Zena. You want to introduce yourself?
Hi, everybody. I'm Paula Zena. I am on the hub team and bring expertise in pediatric nursing and in clinical psychology. I am currently on the faculty in the Department of Psychiatry at Tulane.
And Dr. Zena is also presenting our didactic today. And we also have Dr. Finelli. Do you want to introduce yourself?
Thanks, Dr. Olivier. I'm Juliana Finelli, also psychiatry faculty at Tulane with Dr. Zena. My focus is infant and early childhood psychiatry and perinatal psychiatry.
Thank you, Dr. Finelli. So we are your hub team of experts, and we'll be helping out with clarifying questions and recommendations throughout the session. I'm going to turn it back over to Lena to talk about PPCL briefly, and then we'll go into our didactic.
Thanks, Dr. Olivier. So just to let everybody know a little bit about PPCL, we are the provider-to-provider consultation line, and we provide mental health consultation to pediatric and perinatal providers across the state of Louisiana. So providers can contact us about resources for their patients. They can speak to perinatal psychiatry or pediatric psychiatry that we have on contract with us. We can also help source resources for the practice or the patient. And another big arm of our program is that we provide education. So things such as this echo. We also have a pediatric echo that runs monthly. It's on the second Tuesday of the month from 12 to 1. And we also provide other various webinars for folks to get either CMEs, CEs, or CEUs. If you would like to register for the program, you just have to scan this QR code here. And I'll also drop our website in the chat at some point throughout the presentation. But that's a little bit about PPCL. All right, so now we will move on to our didactic presentation with Dr. Zena. Paula, I will advance the slides for you, and you can begin whenever you're ready.
Okay, well, why don't we begin? Thank you very much, Lena and group. I'm going to talk about ethical issues around decision-making today. We can go ahead and change the slide. A topic that really I'm going to be relying on or talking about some of my collaborators in a project that we've been working on around ethical issues in infant mental health, infant and early childhood mental health, and many of the issues. And I think the approaches that we're talking about, I believe, are relevant for perinatal mental health too. My collaborators are John Korfmacher, is a psychologist who does a lot of research around home visiting in Chicago. Isaac Lim is a child psychiatrist with specialty in ethics. He comes from Australia. Alison Steyer, whom some of you all may know, she was at LSU and at Tulane a number of years ago. She's now out in Phoenix, and she really does a lot of work around DEI as well as reflective supervision and support of people working with young children. And Charlie Zena, my husband, who many of you may know, an expert in infant mental health. So I'll be referencing them later. No disclosures, however. Okay, next slide. All right, so let's just start with a quick poll. A couple of quick questions. I want to get an idea from this audience. Have you ever been faced with a decision in perinatal mental health when it was not clear what was right or what was wrong? Go ahead and if you can, just answer nay, or I don't know. All right, looks like almost everybody's answered, and it looks like many people have encountered some type of dilemma in their work around perinatal mental health. Okay, why don't we try the next question?
Okay, let's see.
And some of you have not really thought about it, so that's good. I'm actually glad to hear that. It's honest of you. And here, I mean, this is just a list of some of the kinds of concerns that might come up, but what are the types of issues that might cause you the most ethical concerns? Safety issues for the mom or the child, inadequate resources. You can read these yourselves. Or you can write in something if there's something else you want to add. That's fine too. Recognizing this is just not this is incomplete. Okay. So, it's a variety of issues, right? That can cause us to be concerned about what's the right thing to do. And I'm sure that, if we were talking, you might have others too. Can we see what the short answer is, Lena?
Let me see. I cannot.
Okay. All right. Well, maybe someone will speak up in a few minutes, but why don't we go on? Thank you guys for answering those questions. Again, as someone spoke earlier, ethics is not something that we always talk about very much. And in fact, one of the reasons I got interested in this in the world of infant and early childhood mental health is because there was practically zero literature on this. There's more in the perinatal mental health literature, but not a lot. So we'll go ahead, Lena, with the next slide. Okay, so this is going to be very brief. I wish we had more time to go through a case in detail, but it's going to be reminders, and then I'm going to be presenting a model for ethical decision making. So very basically, ethics comes out of philosophy, and philosophy of trying to figure out what's right, what's wrong, what's the best thing or the right thing to do from a moral perspective. So this takes us out of some of our usual ways of thinking about things and into the morality of the work that we're doing. Obviously, moral issues affect all aspects of our lives, but here we're specifically talking about those kinds of dilemmas that occur in healthcare. And it's not just the decisions, but often when we look at ethics, we're looking at how clinicians, how we as people who work with families and young children ought to be acting, how we act, how we comport ourselves in relations with patients and families. And I'm going to be using the word patients probably and clients interchangeably, and I'm probably going to be using the word patients, mothers, and caregivers interchangeably, just heads up. Okay, next slide. So if you are at all, interested in the world of ethics, you might be familiar with Beecham and Childress. They're two white men who wrote the book on ethics way back in the early 2000 on biomedical ethics. And they identified these 4 principles as what underline a lot of the work that we do. These are not the only things that underlie work, but they're the ones that they truly emphasized. And at one point we were looking back at the ethics codes of social work, nursing, pediatrics, child psychiatry, the whole gamut of those of us who work with children and families. And all of those ethics codes incorporate these principles, but the detail to which they focus on them or the detail to which they provide guidance really varies from profession to profession. We'll go to the next slide. So I'm going to go through these very quickly. Hopefully this is just a review, but I think it's helpful to get grounded in the concepts that we're talking about. So the first principle that they discuss is beneficence. And that is our positive actions to ensure that people have positive outcomes. So we're relieving harm or suffering. We're preventing harm or suffering. We are promoting the welfare and well-being of our clients and our patients. We're doing active things to make things better. Next slide. Maleficence. It's a hard word to say. This is the first do no harm. You all have heard that from the Hippocratic Oath. Hippocrates, how many thousands of years ago was Hippocrates talking about this? It's not a new concept, but it's still one that we struggle with sometimes because we have to not only prevent the obvious, but we have to be able, as Beecham and Childress say, we are accountable for any foreseeable harm that we might anticipate in a particular decision or action. And those foreseeable harms, to not do something has to be outweighed by the foreseeable benefit. So again, risk-benefit ratio, we talk about that a lot in trying to figure out, okay, what's the best thing to do here given what we know. Next slide. Autonomy. This particular principle really underlies informed consent. It is obviously the ability to make one's own decisions without controlling influences or limitations. That means we're not supposed to be influencing people about what their decisions are. And if you've ever been in the situation of trying to get informed consent and not doing that, it's hard to do sometimes. And because somebody may want our opinion, and so we have to make a judgment. How much information do we give to not persuade someone in a way that takes away their own decision-making ability? And we need to be respectful and support self-determination. I know as a pediatric person, I'm usually turning to parents, but when you go into the adult world, boy, you're on your own. And even if you don't agree with what someone's deciding for themselves or perhaps for their children, it can cause real moral dilemma for us in those situations. Next one. Justice, again, fair and equitable treatment in light of what's owed. What does that mean? Well, we want to be non-discriminatory, but that doesn't mean blind to the differences of what people need as individuals. So that's equity, right? That we are providing care based on the unique needs and strengths of a particular individual, which is really what is meant by in light of what's owed. So we'll just again, this a very, very brief overview of what these definitions are. Next one, Lena. So in the world of perinatal mental health, and even in infant mental health, we know that moms and babies are sort of everybody's business. If we get into big discussions about what's the right thing to do, and I'm going to try to avoid getting into those sticky wicket things, but the whole world has an idea about what's best for moms and what's best for babies. If you've ever been pregnant and walked in a grocery store, you know that your belly is there for everybody to touch and comment on. It's just like, it's everybody's business. And in our own professional world, we have a variety of people working with different disciplines. Probably on this call, I'm guessing, I don't know what all your disciplines are, but I'm guessing we have social work and nursing, and we have psychiatry, and we may have some OB people, and we have, we've got psychologists, we've got a variety of us who are involved in taking care of moms and babies. And we come up from different perspectives, which is great. And it can be confusing, and it can cause challenges when we're trying to figure out what the right thing to do is. Next slide. So in terms of our world, and again, there are papers written on this, the kinds of things that typically come up that cause ethical dilemmas, if you will. And what's unique is the fact that we have two people to think about. We have the mother or the caregiver, and we have the fetus or the infant. And what's right for one may not be what's right for the other. So we have to kind of figure out how do we, who are we taking care of, how we're making that decision when something done for the benefit of one might be harmful to the other. We do things like prenatal care, substance abuse for substance using mothers, who are pregnant. We provide vaccines. Many of our actions are intended to be beneficial to both, but they don't always end up being that way. We get into safety issues around things like maternal depression and psychosis. So we often talk about how to treat the mother, but we also need to think about if that mother is not adequately taking care of the child in a safe way, at what point does the mother lose her ability to take care of that baby, and someone else must do it instead for the baby's benefit, to ensure that the baby has safe care. So we run into ethical dilemmas there. We may some of you all mentioned treatment of rural areas, or at least on the lack of treatment availability. So if you're working in a program that doesn't deal with mental health, and yet you've got a person with a mental health issue right in front of you, and you don't have access to resources, what's your ethical obligation to address that? So rural areas, lots and lots of areas where treatment unavailability may be an issue. Certainly in the area of undocumented people, where they are, you can get your license, you can be thrown into jail if you're taking care of certain types of people. So it affects not only do we provide care for those, but what's going to happen to us as well. Next slide, please. So just to make the point that not all ethical decisions are big deal ethical decisions. That's my very informal way of saying it. Our ethical decision-making occurs in pretty much all the clinical work that we do. It's hard to think of a clinical decision that doesn't involve, is this good for the patient? Is there potential harm? But when we get into challenges is when it's not clear, or when we're not all on the same page and so forth. So we argue that it's really important to be intentional about how we're weighing the factors that contribute to our decisions, and in particular, the ethical dimension. Next slide, please. So my colleagues and I, like I said, we've been talking about this a lot through the world of infant mental health, trying to figure out, sort of how do we think about the various factors that go into ethical decision-making. This is our version, our current version. At one point, we were thinking about lenses that would be sharper or fuzzier, depending on what the issue was. This is actually a methane molecule. We are not chemist here, but we liked it because it shows that all the dimensions that we're going to talk about in a second are all related to each other. And in this particular model, we believe that certain dimensions may be more pertinent in certain situations than others. It may not always be pertinent. But I'm going to go through each of the dimensions and just describe our thinking and where we are with this, so you have a flavor for what the dimensions mean. So go to the next one. So the clinical dimension is that which we are all trained to do, right? It's what we learn, our scientific and theoretical knowledge base, what we use for evidence-based practice, clinical guidelines, our technical expertise, our knowledge base, what we learn in school, that helps us figure out what we need to do. We also have to consider the relationship that we have with clients. Again, Hippocrates, way back in the day, they knew that the quality of the relationship between the physician at the time and the person really mattered in terms of healing. Now, people typically come to us because there's a problem, but we also want to be thinking about what are they bringing in terms of strengths? How can we engender hope and a sense of recovery when people are coming in under some types of distress? And for those who are working with young children or even the developing fetus, we've got to think developmentally, what's happening now and what's going to affect that child now and down the road in terms of our decision making. So we want that developmental lens as well. Next. Context. We back out a little bit because where we work matters, and where we live and where we work matters, right? So our programs have certain scopes and limits to what we can or can't do. We can't do everything for everybody in every program. We only have certain limits. We have certain rules and regulations that we have to follow. There may be organizational norms about what we can do. I'll never forget someone, a social worker at one point, talking about working for child protection, and she said in this particular case, what the agency felt was adequate for the family that lived in a very rundown trailer was like a cooler that had ice in it instead of having a refrigerator. And that was just like not okay for her. That wasn't adequate. She ended up quitting because that was morally distressing to her. And so but that organization deemed that this was sufficient. Leadership and supervision. In many of our programs, we now have reflective supervision available to help tease through some of these, but we know that people are not necessarily trained about how to think about ethical issues in reflective supervision, and people vary in their skill being able to do that as well. Again, you know, the historical context that we're in, certainly the political context that we're in right now. Again, I'm not going to go into all of that, tempting as it might be. But you know, certainly the kinds of issues that we're talking about now around moms and babies have lots of ethical considerations there as well. Next one. Legal dimension, legal and ethics issues are often, you know, just hand in hand. I went to a wonderful ethics training a couple of years ago, and they were giving case examples, and all of their cases were legal cases. And I'm saying, wait a minute. It's not just because it's legal doesn't mean it's ethical, and just because it's ethical doesn't make it legal, you know, so that we do have to follow the law oftentimes. But for example, when we're trying to make a decision to refer to child welfare, we know there's lots of gray areas about when we do that. It's not cut and dry about when someone needs to be referred for that, for example. So even though there's laws, they're not always as clear as they want to be, and there's gray area for us to consider some of the ethical implications and vice versa. Next slide. And then personal dimension. This is maybe my favorite one, just because I think most of us probably get into this world because of our own personal values and beliefs. Maybe it's a religious thing. You know, for me, nursing was a calling, you know, and we want to help people. And maybe we think because of our personal experiences, we bring certain knowledge or experiences that will help other people in similar situations. So it's very, very powerful in our world. That, of course, can lead to issues around countertransference, which is basically when we get pulled in one way or the other in a very strong way to certain patients or families or situations. And oftentimes that's because of our own personal values or beliefs or experiences, maybe conscious or unconscious, but we may feel particularly connected or particularly disconnected from people. And that can affect our decision making. And that's an ethical issue where we have to really think about, where am I on this dilemma personally? Speaks to our reflective capacity. And of course, professional competence, as far as I could tell, when I was reviewing the ethics codes, most require us to be professionally competent, and that's up to us. That's on us to do that. Somebody was talking about getting their CEs earlier, but we do need to do that for ourselves as well. So personal dimension. Next slide. So, you know, some of you said, I don't think about it that much, and that's okay. That's okay. But I think it's important that when we don't consider the ethical dimension, what can happen. I want to give a very quick, brief example of a situation I heard of a while back where this was in a hospital setting, and it was in a NICU, and the physician, you know, the family was dealing with a very sick baby. Should the child go on to comfort care? And a new physician comes in, changing of the guard each month, and he says, babies don't die on my watch. They don't die on my watch. We're going to do everything we can, even though the family had already decided that they were leaning towards letting the baby die or stopping over treatment. So in this case, this man, it turns out he had been a preemie himself. He had lots of personal issues that were involved in this decision, but that kind of blindness to his own experience and so forth can lead to over medicalization, or it can lead to conflicts with clients or patients when we're thinking one way and the professional comes in and says something else. Poor outcomes and poor care. It can also lead to our own problems with burnout, compassion fatigue, in particular moral distress, where the moral dilemmas are really get to us. And we know that in fact moral distress comes out of a lot of the nursing and medical literature, but so we don't have the numbers that I would wish we had, but we know that 30–40% of people probably experience moral distress in the kind of work that we do. Okay, next slide. And then the ethical dimension, we consider this the center. Everything kind of goes back to the ethical dimension. We need to be explicit. What are those principles that we're leaning on? What are our professional values and virtues? What does it mean to be a good nurse, a good child psychiatrist, a good social worker? What are the things that we tell ourselves? I go home today and I was a good nurse today because I did blah, 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 or I acted in a certain way. We certainly have our codes of ethics we have to lean on, and we should be, knowledgeable about. We're looking more and more at things like parental rights and child rights. The World Association of Infant Mental Health just came out a couple of years ago with infant rights. We tend to lean on the parents for the infant rights, but infants, as we learn more about babies, maybe have their own set of rights. Certainly our personal, moral awareness and strength in our decision making, and for us, we've included DEI under the ethical dimension because it's so closely tied to things like justice and equity and autonomy and those kinds of things. All right, next slide. So how do we use this model? I'm about ready to run over time here. We're not really sure, to tell you the truth, because this is pretty new, but we think we can use this either as individuals or as a group in thinking about which dimensions should we weigh, what part of each dimension are contributing to our ethical or our clinical dilemma. And like I said, some of these may be, some of the dimensions may not be contributing at all. In some cases, they all may be there. So we have to really weigh those, pay attention to those, think about what the underlying ethical principles are. Oftentimes there's more than one ethical principle at stake here, and then try to figure out what are the ethical priorities. So that's kind of our thinking at the moment. That again, an intentional approach to ethical decision making. Next slide. Okay, so resources. We do all need probably to learn, continue to learn about ethics and our own personal education. I like the word courage because it takes courage sometimes to bring up an ethical dilemma. Sometimes we rush through decisions because we just want to get something settled. And it takes courage to say, wait a minute, we need to think about the ethics of this. We often turn to our colleagues and team. That's fine. That's kind of the first line of business, I think. But we need to also be aware that we can have groupthink. We can all be thinking the same way, and we may not challenge ourselves for all aspects of an ethical dilemma if we're talking to the same people all the time. In hospitals, there are ethics boards. And so that's pretty common in hospital settings. It's not common at all in the community settings where most of us work. I never really thought about that until I started getting into this. And, how do we solve ethical dilemmas in these other settings? Their thing, and or to make an explicit way that you're educated, or that you challenge cases on ethics, make it intentional at this point anyway. Obviously, if you're a member of American Nurses Association or APA or NASW, whatever, many of those organizations have someone you can call and say, I've got this issue going on, but they may or may not be well-versed in the issues around perinatal mental health. I just want to add that because, again, I think there are unique concerns that may or may not be part of the standard way that people think about ethics. So I think this is about it. Rushing through here. Next. Oh, okay. So again, thinking about ethics through all of our clinical decisions, thinking about the unique concerns that we have, I would like to see more discussions, more case discussions, more presentations, more papers really kind of going through, you know, what is it about how do we come to terms with some of these very, very difficult ethical dilemmas? And we have to be comfortable with being uncomfortable. We have to really agonize and grapple, and that's okay. But we want to be intentional about it and see the value in doing that. So anyway, that's the end for me. I know it's fast. I'm sorry we didn't get a chance to talk about a case, but if you have questions or have any comments, please feel free to email me at this address. Thank you.
All right. So I did drop in the chat the link to complete your survey for CEUs, CMEs, and CEs. The link will be live for 72 hours. We will also send that out to everyone in an email after the session. Let's see, our next session is Tuesday, April 22nd from 12 to 1. If you have any questions, please feel free to reach out to us at PPCL@LA.gov. Also, please consider signing up to present a case. The sign-up sheet is in the chat. If you have any questions or comments, we will stay on for a few minutes after the end of the session. But we look forward to seeing everyone at the next session. And that concludes our ECHO session for the day. Thank you all for joining, and we'll see you next time.